All right, so the need for a public health system. What's wrong with our current system? I mean, we all kind of know we run up against the behemoth that is our privately funded for-profit healthcare system. Anytime we need to, anytime we seek any sort of preventative or maintenance or remedy from the medical system. So some of the things that are wrong, because your wealth determines your access to treatment or ability to pay for it, the system values enrichment of the healthcare sector over actual health and dignity. That just gets back to the root of what we're talking about it with it being a privately funded system, which means that we have this large insurance lobby that acts as a mediator and a gatekeeper and really serves to do nothing but dole out healthcare goodies to the rest of us. The soaring cost of healthcare contributes to many burdens for the public. Listed here, you can see them: loss of coverage, inadequate coverage, medical bankruptcy, financial rationing. It's other issues with it, of course, are with those premiums, with those high deductibles, with the fact that they go up every year. It means that administrators at insurance companies get wealthier and wealthier, while the rest of us find it harder and harder to pay for healthcare. Being a union officer, I see it all the time. We had a huge crisis where we had to shovel money from other benefits into our healthcare fund, and all it really served to do was, it didn't get us anything better for it. It just bloated the cost for our members. And despite the fact that healthcare is not available to everyone, we spend more on healthcare per capita than any other rich country. I know I looked a while ago when I first started getting into the idea of Medicare for all and saw the second highest at the time. Sweden paid the second highest cost per capita in the world. We're paying half of what we pay in the United States. It's absolutely absurd. So if we click to the next slide. The current system is profit-driven, as we discussed, and employer-based, which obviously means if you go to a job, that's where most working class people get their health care. If you lose your job, what happens? You also lose your health care. It's not recognized as a human right in our current system. And also, sick people are expensive to insure. So insurers coerce them into taking on more of the cost themselves. And another effect of that, I'm sure there are people on this call who can speak to it for sure, that when you're coerced into taking on more of the cost, that means you're not going to seek treatment out when you need it. It also means that you are going to avoid preventative measures that may save money for you and for the system in the long run. But we all know that in our current capitalist model, it's all about the next quarter of profits. There's no concern for what it means even for the system itself. It almost works like an Ouroboros consuming itself, where it has to continually find something else to feed into the system. And so sick people are told to pay for most things for themselves. And then obviously our version of emergency room care is sort of the national version of, I shudder to call it universal health care, but that's what they tried to call it in the 70s when they were passing the HMO bills and everything. That's how people who don't have insurance can seek treatment, but then those costs are passed on to insured people as well. So can we pass to the next slide, please? Like I said, in Sweden, they pay half of what we pay. They also get significantly better outcomes, even though they're also a privately funded system. They are a universal healthcare system, but on average, we pay 3 times per capita what other high-income nations pay for healthcare. But next slide. So what do we get? We rank among lowest in life expectancies. We rank among the highest in maternal and infant mortality rates, and we are at the very top of the chart for deaths from preventable diseases. This goes all back into what we're talking about, where low life expectancies and deaths from preventable diseases are all because people avoid seeking treatment when they need it, because they are taught to see themselves as economic inputs and nothing more. It is, okay, I can't afford to do this. This may kill me down the line, but right now I know I can't afford to do this. I have to pick between, simple healthcare, prophylactic treatment, or putting food on the table or paying rent. It's absolutely disgusting, but that contributes to all of it. It contributes to low life expectancies and dying from very easily preventable diseases. So we're all uninsured or underinsured. Even before the pandemic, 87 million Americans were uninsured or underinsured, which means you can't afford your health care. So you may as well not have insurance because of the high cost of deductibles and premiums. And 60,000 Americans die every year from lack of health insurance. That's a good, decent sized town every year just wiped out because they couldn't afford health insurance. And for some perspective, there's 320 million people in this country. That's well over a quarter of Americans who essentially are uninsured. Even if they have insurance, they're just paying into a system they can't afford to participate in. So those of us with insurance bear increasingly unaffordable premiums, deductibles, and copays. Again, my union went from paying roughly $7 and some change per hour per member for healthcare to over $9 an hour. We had to take it out of our own retirement. There's no help from the insurance company or from the contractors in doing that. It's something we had to shoulder ourselves. And 5.4 million more Americans lost their health insurance during COVID, during a time when, you know, most other countries are ramping up healthcare. We saw the ugly truth of all over again of how our system works. It doesn't matter if there's a once in 100-year pandemic, people will lose their health insurance because they're losing their jobs or simply because they can't afford to pay for it themselves anymore. And a third of COVID deaths are linked to underinsurance, which, you know, that's how many hundreds of thousands of people have passed away and would still be with us if they were able to access healthcare and get past that gatekeeper. And in New York State alone, our state, there are over 1 million who are uninsured and millions more who are underinsured. And that is a big thing that, you know, the health insurance lobby likes to tout is, oh, only 5% of New Yorkers are uninsured, which any percent of New Yorkers being uninsured should be unacceptable. Being uncovered, not being uninsured, but being unable to access healthcare when they need it. And the many more who are underinsured may as well not have insurance either. So why? Health insurance CEOs make $20 million a year, which is $385,000 per week. I mean, I think most of us worked for a few months on that kind of a salary. We'd never have to worry about healthcare or any other costs again. It's absolutely obscene that we have a system where what should be a public good is treated as a commodity, and the only reason for that is in order to fill the pockets of CEOs and shareholders on the boards of these companies. So the administrative bloat of health insurance companies, I didn't even read that next line, but is obscene. Absolutely. You know, it's absurd that I think about it a lot, like nobody working, if you can't think of a government employee who's making $20 million a year, even at the head of their post. I mean, even presidents, senators, and Congress people, the most corrupt of them would have a hard time pulling in that kind of money per year. And this is because we don't treat it as a public good. It is a for-profit system. And the healthcare insurance industry made $54.6 billion in profits during the last quarter in 2020 alone, which, if we remember, was a time when most non-COVID related healthcare treatment was mandated to be put off. That was just starting to come back at that time where offices were opening up. So they're making $54.6 billion in profits off of people who absolutely needed to get taken care of. And that is absolutely unacceptable. We do have a solution to stop this, though. Universal single payer healthcare, which some people may be saying, what is that? I think most of us know what it is by this point. If you're on this call, you probably do, but let's go on to the next slide. So everyone would have access to quality healthcare regardless of income. By pooling everyone into one plan, we have much lower overall healthcare costs. We get rid of all that administrative bloat. There's no more sick people burdening all of their own care costs. There's no more bilking off of what little coverage people do get from Medicaid. There's no more, you remove the parasitic middleman industry that just gatekeeps healthcare from all of us. We pool everything. I mean, Bernie Sanders famously, on a Fox News town hall of all places, they asked him, well, isn't your plan going to raise taxes? And this is Medicare for all. It's slightly different from single payer in New York, but that's the ultimate goal that we're trying to get to. And he said the average family pays 20% of their wages in healthcare. And under his plan, it would be 6% of your income would be taxed, and that would cover your healthcare. And he said, who here would trade in 20% for 6%, even if it was a tax? And everyone's hands go up. This is how you save. This is absolutely how this plan works, and it saves money. There's a reason no one else in the world is absurd enough to try the system that we have in this country, and there's a reason we don't hear very much about how other systems work. It's always about the long wait times in Canada, but I can tell you, I need a new general practitioner. I've been on a list since June, and I won't be seen until November. So long wait times are not specific to single payer models. Next, please. So more choice. You choose any healthcare provider you want, and all procedures and medications are covered. Even I, having excellent union health insurance, I have a network. I have to see doctors in that network. And if I need a procedure, often I have to go through my doctor to get a referral. And then there's copays on any medication that comes up. And I honestly have pretty decent private health insurance, but it is obscenely expensive, and there are still barriers. I can't see any doctor I want. This idea that you get a choice if you are in a private model, like the right wing likes to say, is absurd. Anybody who's ever dealt with a network knows that that's not the case. So obviously there's lower administrative costs, because whoever's at the top of this is going to be a government official and won't be making $20 million a year and doesn't have a board of shareholders to make money for, to turn quarterly profits for. And providers freed from administrative work can spend more time on patient care. My mom is a seasoned nurse, and I'm sure she could have been very well used during the pandemic. She's been a nurse for over 25 years. She's just an administrator. All she does is administrate. And she tells me all the time how she would love to get back into actual healthcare work, but the incentives don't push the best to actually be involved in the system. They push them to do paperwork, to be administrators. And it addresses the roots of healthcare inequality, because if you're taxed based on what you can afford to pay, but you have access to the system like anyone else, essentially treating it like a public good, like a road or a school, that absolutely would help. Those million people without health insurance and the millions more underinsured in their state instantly are on the books again. So why in New York? Excuse me. So New York is one of a handful of states with an active single-payer healthcare bill, the New York Health Act, which we are talking about. It is likely the most viable bill of its kind in the country because it has the votes to pass through co-sponsors, which means enough people in both the Assembly and the Senate have co-sponsored the bill that if it were brought to the floors for a vote and only those co-sponsors voted for it, it would pass. Now more than ever, New Yorkers need protection. We're all living through this pandemic. We all know that that's the case. And if we pass the New York Health Act, we set a precedent for Medicare for all for the rest of the country. This is the 10th largest economy. If New York were a nation, it'd be the 10th largest economy in the world. There's no reason we can't afford to do this. There are an obscene amount of even more obscenely wealthy people living in this state. There's no reason we can't do this. I believe is this the end of my portion?
Yeah, thanks, Andre. And now I'm gonna kick it to Zach, who's gonna go through the specifics of the New York Health Act.
Hey, I'm Zach. I'm in New York City and a member of CWA Local 1400. So I'm going to be going through what this New York Health Act is actually going to be doing for you and your family, for myself and my family in the city of New York. So I'm just going to list off a couple of things. First and foremost, we will have no more network restrictions. So no more agonizing whenever you have an issue over which doctor is or is not covered, or if God forbid you have an emergency, not having to risk financial ruin by going to a hospital that's going to save your life that happens to be out of network. Number two, generally having all medical decisions be between you and your doctor. So there's no insurer saying like, oh, well, even though your doctor recommended this treatment, we can absolutely have, we actually are only going to be able to pay for this lesser treatment and force you to continue on and be sick. Third, it's going to allow every New York resident and those who work in New York but live elsewhere to actually enroll in the New York City Health in the New York Health Plan. So there are quite a few workers who are living in, say, New Jersey or Massachusetts or Connecticut who commute to work but work in New York. Those would be covered as well. And number 4, and most importantly, cover all medically necessary services. Like there is nothing here that we are leaving behind. So I think a lot of what Andre was talking about, specifically the sort of tiered systems that we have, NYHA is explicitly here to prevent a tiered healthcare system. No more are we going to have the obscenely wealthy or the absurdly rich generally having a much better healthcare system than those of us not making that much money. We're all having the same system. We're all universal, and everyone gets the same good care. So the big question, one of the big questions, how will we actually fund New York Health Act? This is one of the first things anyone usually asks. But yeah, so the good news is the New York Health Act is actually revenue generating. So it is there's a progressive tax structure. It's actually built into the bill, and we'll cover that a little bit a little bit later. And it actually makes the New York Health a self-sustaining system. So we're not going to have a budget deficit due to the New York Health Act. The New York Health Act will actually help a budget deficit in the state of New York. All we're doing now is just redirecting the flow of money in the state. So New York doesn't actually need to cut any essential or existing social programs to fund NYHA or to fund NYHA. So yeah, that's a huge bonus. So let's compare our two systems. The first, horribly complicated. I don't even want to read this, I'll be honest. But it's very much split up, and you have a lot of middlemen. You have a lot of middlemen from the private insurers that are generating a lot more transactions, places where money is sort of siphoned off, and places where a lot of these sort of healthcare executives can get all of their money. All that $20 million is coming right out of private insurance. So onto the New York Health Act. So this is our system. It's still a little complex to read, but it's much cleaner on the right-hand side there. So between healthcare providers and the New York state government, which would take over for the private insurers, you're seeing just a much more simplified and much more streamlined healthcare service, a lot less money being leaked out, much better care being given to everyone who's using it, and I think a much better life for the healthcare providers. So where is our money going right now? Primarily, it is premiums. So whenever you actually use your insurance, you're going to be paying some kind of as you have your insurance, you're going to be paying some kind of a premium. And currently, employers pay on average about 20% of that premium. And in cases of a union worker, a lot of those premiums are a bit lower, but we have just still a lot of premiums being taken for our money. And also out-of-pocket payments. So just copays, reinsurance, anything bought without insurance, are these sort of copays or out-of-pocket payments. They're also going into taxes. So we have a 2.5 federally, we have a 2.9% payroll tax and a bunch of non-payroll taxes. In New York, we have quite a few state taxes. In the city, a lot of local taxes. And then one interesting point here is that a lot of the employer-sponsored insurance is actually written off for workers, generally considered a business expense for corporations. So a lot of them can actually make money off of giving you healthcare or sort of giving you substandard healthcare. And the US government's leaving a lot of money on the table in doing that. So under NYHA, how are these flows of money going to change for you? The first is, well, it's actually going to be funded, and that flow of money is a progressive tax, like I said before, that's built into the law. And secondly, restructuring a lot of the money that's already being spent on healthcare with those private insurers and moving it more towards public sector. So we get a gigantic pool of money and make sure that everyone in New York can actually have good, decent healthcare no matter what. So for the taxes, we have sort of a combination, right? We have a new tax, mostly a payroll tax, which is going to be split 80-20 between employer and employee. So we're kind of flipping the current relationship, and a non-payroll tax on income that's not subject to payroll taxes. That's taxes on assets, capital gains, things of that nature. And finally, the old taxes, the things that will not change under the state law. So federal taxes, you'll still be paying those, but they're going to be going into Medicaid and Medicare, our federal programs, which is just going to be going directly back to New York to help pay for this. So cost to the state and cost to us. So I'm just going to run down all four of these. First, you have the state of New York's health tax revenue, a progressive and income-based payroll deduction, and various deductions on capital gains, the interest and dividends, the things I mentioned earlier. In total, we're going to see actually about $140 billion from this, and that's coming from the RAND report, which is just sort of like a general report on how this would change with something like single payer healthcare in the state of New York. 2, federal Medicaid and Medicare funding, which is, like I said before, going to be rolled directly into the New York Health Act and the New York Health Program. In general, we're going to have no point of service costs. This is personally my favorite thing. We don't have a copay. There's no co-insurance, no premiums, no deductibles. There's no, worrying that when I'm going to the doctor, even though I have insurance, I'm going to get a massive bill, some gigantic copay for apparently no money, or for a ton of money. And finally, generally efficiency and fiscal responsibility. So we're trying to save the state billions of dollars by not paying these very extremely high administrative and CEO salaries and sort of generating their profit margins for them. So yeah, this is a bit of a tax proposal. This was used in the RAND report. And this was already a relatively progressive tax scheme that we have made even more progressive in the current iteration of the bill. And so when I say progressive, I mean leaning more towards taxing the wealthy over taxing the poor and the middle class. So in reality, right now, the actual tax scheme is still a little bit undecided, and it actually probably could be far more progressive than it already is. A new law already excludes raising taxes on those in the bottom 25% of earners, so this specific scheme can't be used. So we'll need to sort of it's forced to be made more progressive because of that. So generally, people in the bottom quartile of income will actually receive healthcare without paying anything at all more. And finally, the reason we're all here, why the hell hasn't this passed yet? This all seems very good. This all seems very fiscally responsible. If anything, to me, the state of New York should have passed this long ago just to help with our budget crisis. And so it's a couple of reasons. The first being we have a majority in both houses of Democrats, but it has not been given a floor vote yet by either Speaker Hastie or Majority Leader Stewart Cousins. And that's for a reason I'll get to in a second. Which is, public sector unions are actively opposed to this. So NYSUT, CC, DC 37, and the UFT, all of their leaderships have come out against this. And in the last legislative session, both Stewart Cousins and Hastie cited their opposition as the reason they didn't bring the bill to a vote. And finally, sort of connecting both of these, hospital and insurance lobbies have an objective financial interest in making sure this doesn't pass. We've talked a lot about making sure we don't have these CEOs, these general administrative costs that are way too high and fill not much of a purpose. And so they are actively lobbying the Democratic majority to not have this happen. I think right here I pass it off.
Yeah, thanks, Zach. And now I'm going to kick it to Nick, who's going to go through sort of how union healthcare plans currently work.
I think Stu first, and then
I'm sorry, Stu's going to take.
Yeah, this was mine. So yeah, hi everyone, I'm Stu Sherman. I am a UAW 9A member through ALAA, the Association of Legal Aid Attorneys. I work in a medical legal partnership, meaning I run free legal clinics at hospitals and health centers throughout the city, and have a couple decades of health policy experience in and out of government. And I'm a type 1 diabetic whose insulin has increased 1,200% over the past 2 decades. So I'm very committed to this cause for personal reasons, as well as for sort of general recognizing how broken the system is. So unions oppose this, and I think it's really important to see how union healthcare plans work and why that might have led to some opposition. So next slide. So the history of employer-based U.S. health insurance really starts sort of the late 19th, early 20th century. Basically, healthcare wasn't much of anything until the early 20th century. Germ theory wasn't really adopted until about, I think, 1890. And so people saw doctors that were paid by the companies as basically shills for corporations, shills for the company town to help them get back to work and not really for their own best interest. As healthcare developed, it became an industry itself, and the medical profession and hospital industry effectively killed the inclusion of national health program into the New Deal. There's a lot of discussion about how important a national health program would have been in the 20s and 30s, but with all the other programs being implemented, they were effective in making sure this wasn't included in the New Deal. So next slide. Since there was no public health program, there was the development of an alternative. And the 1930s saw the development of what is the first group health insurance as a private sector response to the lack of national health care. So this was, the first one was Blue Cross, and then it came Blue Shield. In order for these plans to work, they needed a mixed risk pool to avoid the death spiral. And a workplace had an ideal risk pool, so it became an excellent market for these plans. And I'm just going to break out for a quick second to explain the insurance's model, business model, and how they work, because I think that's also important to understand. Basically, on a very simplified level, members pay premiums to health insurance companies. The health insurance companies pool all these premiums into reserves, which are large chunks of money. And out of those reserves, they pay for claims made by members for health coverage. So this is the model of all insurance. It's kind of preposterous in health insurance because there is 100% certainty that you're going to need healthcare at some point. But the same model that was used for other insurances was applied here. And premiums are set based on how many claims they expect to be made. So you need sufficient reserves to pay for all those claims. In order for this to work, they need a diversified risk pool. Otherwise, they'll keep having to pay higher and higher claims and they'll need larger reserves. The concept of a death spiral is in which the only people that purchase health insurance are people that are high users of it, leading to increasingly higher and higher costs until no one gets health insurance. When this model of using insurance for healthcare was applied, initially employers took it as a benefit that they could give employees, and it was entirely covered by employers. Next slide. So Blue Cross, the first of these, grew very rapidly from its foundation in the 30s to by 1940, it had 6 million members who enrolled in about 56 different Blue plans. And by 1958, it had 52 members in about 79 plans. That's 30% of the US. By 58, about 3/4 of the 123 million Americans with health insurance were participating in employee-based programs, and 36 million had a plan that was collectively bargained. So unions were at the very beginning of health insurance in the country. Because we didn't have a nationalized health plan coming out of the 30s, it became an employer-based system, and unions, as they grew, became very involved in negotiating this benefit. Next slide. Just a little more information on the collectively bargained nature of these benefits and how the number of collective bargaining agreements doubled from I think it's 600,000 to 1.2 million in the late 40s. And in the 48 to 50, it jumped again, by scores. So by the mid 50s, millions of workers and their dependents and their families had health insurance through collectively bargained health plans.
What?
Go, next slide.
You can say no.
So someone go on mute if you're thanks. So there's two-ish types of union health plans, basically. One would be an employee managed plan. Now I broke this down into ERISA plans as well. Basically, in this one, the employee manages the plan, the money, and is on the employer side of it. And so the employer pays for partial premiums, the employee pays for part, and it's a separate company that maintains the reserves and pays for the premiums and pays for the claims. The difference with an ERISA plan is that the reserves are maintained by the company itself. It's not a separate corporation, a separate insurance company. It's the company itself that is providing the health insurance. But functionally, a lot of these look the same because the front end is usually managed by, let's say Cigna might manage the front end, even though the reserves are maintained by IBM. And then the second is the union managed plans, in which the union members get that coverage. So let's go into a little more detail. Next slide. So in the employer managed plans, employers contribute toward the health insurance. They can pay for the entirety or cost share with employees. Most of them cost share with employees, and this is a major source of negotiations, how much cost sharing there is. the employer is in charge of negotiating with the insurance company, including what's part of the union, what's part of the contract, the health insurance contract. Actually, recently had a fight because one of my durable medical equipment, glucose sensors, has tripled in price because of a change made in the contract between the health insurance company and my employer, which the union was notified of. And the insurance company actually wouldn't even let me see the contract because it was proprietary and only my employer could see it. So the negotiation on what is and isn't included is on the employer's end, with the union making negotiations on what they want that to look like. Again, in the ERISA plan, the employer finances and maintains the risk pool, and the benefits are managed by a third party. In addition, employees can opt into different levels of coverage. Sometimes employers give them levels of coverage based on the amount of cost sharing they're willing to provide, and different plans that are sort of in the menu of options. Okay, next slide. So the union managed plans, Taft-Hartley plans, you know, I think of these a lot in terms of a more guild model. I don't know if any IATSE members are out there or anyone's in a similar program, but basically with these, the union negotiates with the employers to contribute a certain amount towards the plan per hour of work by employee. The union manages and negotiates a plan with the health insurance provider, and anyone who is a qualifying member of the union is eligible to enroll in the union plan. These are called Taft-Hartley plans, and you can see the sort of separation between who manages the contract and how the payment and money flows. It's also possible for unions to have both an employer managed plan and a Taft-Hartley supplemental plan as well. Next slide. So union opposition to the New York Health Act and their union opposition to other single payers. So this isn't unique to New York State. There have been unions that have opposed Medicare for all across the country. And the reasons tend to be similar. One is that the benefits that union members have are hard fought, and there's a inherent resistance to changing an entire system, which would eliminate a need for one of those benefits. There's this fear that the coverage they would get might be worse, and that they, gain some political power and leverage by having provided this benefit to union members. In addition, there's claims that any savings from the New York Health Act would accrue on the employers and come out of the formerly hard-fought union benefits, so that if there's general savings from having a state health plan, the benefits would actually, basically if you negotiate a contract and you put a lot of resources into getting healthcare. Well, if healthcare is no longer an issue in your contract, they're worried that as opposed to money getting back to employees, it will go to the employers. Next slide. So also health insurance benefits and ability to negotiate them, is a major recruitment tool to gain new membership and new shops. The power of unions to fight with management, to have historical victories, and to win health insurance and high quality health insurance is a strong incentive for places to unionize, as well as for people to join unions, especially in the sort of Taft-Hartley model. There's also the claim that these high quality union benefits would decline. You'd have worse coverage under the New York Health Act, or you might, and that risk alone is enough for them to be afraid. There's also this specific risk of out-of-state retirees losing health coverage. So retirees also get health benefits. Over 65, you can get Medicare, but people also need supplemental coverage because Medicare is only great when you don't have it. There's a lot of gaps in it, and so there's this fear that anyone who's out of state might lose that supplemental coverage they get. Next slide. There's also the specific Taft-Hartley welfare fund opposition. So where it's a sole Taft-Hartley fund or a supplemental, they have large reserves gained from those premiums, and there can be a high administrative costs as well as salaries. UFT is a good example of this. They have if you're a UFT member, you have union benefits, but there's also this separate welfare fund, which has $500 million inside of it. And the people that manage that UFT welfare fund have salaries up to $300,000, as well as other jobs associated with it. So it's basically losing an entire side business for people in sort of sub-executive levels of these unions. There's also the appearance of a more expensive insurance. So the New York Health Act might appear expensive to employers and employees insured under these funds because currently these costs are invisible. For employers, they just pay a set amount and the union sets aside some of that for the cost of insurance. So the way that that model works, it might be harder for people to map that savings, and that makes them much more resistant and reluctant. So next slide. I think I'm done. Yeah. So I am finished, and I think is Nick's next.
Yes, I'll take it from here. Thank you, Stu. Hi, everyone. Good evening. Good to be with you. My name is Nick Shearman. I'm a member of DC 37. Specifically, I'm in Local 371, which is one of the social service employee locals. I work for New York City Parks in the Capital Division, helping build and rebuild the city's parks. I am a proud employee of the city, a proud union member, and proud to be an advocate for the New York Health Act. So in this section, I'll be speaking about why New York Health Act is good for union members and addressing some of the concerns that Stu just laid out that the public sector unions have. Next slide, please. Okay, and all the speakers thus far have spoken about the incomplete care that is part of our current system. So under our current system, the healthcare benefits secured by unions are some of the strongest out there. But unfortunately, those plans do not necessarily guarantee comprehensive care like dental, eye, mental, or long-term care. And they can still require premiums, co-pays, or deductibles, which we've spoken about. For example, as a New York City employee, I'm a member of a Gold Preferred health insurance plan. It's a very strong plan comparatively under our current system, but there are still gaps. It's incomplete. Dental and eye care are not included in the plan. These services are covered by my union. But I've found that the eye and dental care providers offered through the union have been hard to get a hold of, to make appointments, quite limited. And it's taken weeks or months sometimes to get an appointment. In terms of mental health care, personally, last year I tried to find a mental health care provider, therapist, and it was very difficult finding one within network. Most co-pays for providers out of network were $100 or more per visit, which is just unattainable for many working people and can cause medical debt. Also, union negotiated healthcare plans still have out-of-network restrictions, prior authorization rules, uncovered prescriptions, or other insurance-based restrictions that limit coverage for union members and increase our medical expenses. I've run into each of these issues trying to see doctors and resolve medical problems in my 2 years of being an employee in New York City. The paperwork and administrative hurdles to overcome these issues also can take weeks or months. Another part of the incomplete care under our current system is that if you lose your union job, there are few healthcare options to cover you if you're unemployed. Unfortunately, for many of us last year, this was a major possibility or sadly a reality. The New York Health Act would cover us no matter what under the proposed single payer system if we were to lose our job, really increasing our state's social safety net, and it would be a major improvement over our current setup and life-saving. Next slide, please. And as discussed earlier in the presentation, the New York Health Act would provide all medically necessary services. So that includes primary, preventative, specialists, hospital, mental health, reproductive health care, dental, vision, prescription drug, and medical supply costs. More comprehensive than the current system that we have now. New York Health Act would also prohibit limited or restrictive provider networks. This opens up people's options of which doctors they can see and want to see. And I'm seeing in the chat, yes, and long-term care, very important. And yes, so really the NYHA system would increase our freedom of choice in healthcare. Next slide, please. Okay, so our working group in preparing for this presentation and in our advocacy looked at what current health insurance plans cost members of 3 different unions who make a mid-range salary for that union. Specifically for the public sector examples that I'll speak about, the calculations are estimates based on averages, and so they may change slightly person to person. In our analysis, we found that the total health insurance costs for each member, so those are the costs paid by both the employee and the employer for healthcare coverage each year, would drop 10,000 or more every year for each union member. Imagine what you can do for you and your family with that much more money each year. Next slide, please. So here's an example of the healthcare costs of a private sector union member making $70,000 for annual salary. This specific example is from the SMART Union, sheet metal workers local. The total cost to the employee under this breakdown and the employer for insuring that person each year under the current system is over $18,000. You can see that on the left-hand side. Under the more efficient and streamlined NYHA system on the right-hand column here, the cost of insuring the person per year would be around $5,000. This represents almost 13,000 in savings per year, a significant drop. Next slide, please. The United Federation of Teachers, or UFT, is a public sector union. It currently costs around $23,000 per year to insure a teacher, making an annual salary around $65,000. You can see that on the left-hand side. Under NYHA, on the right, it would cost under $5,000. This is almost $18,000 in savings that could be applied to wages, pensions, or other benefits that working people need. Next slide, please. The same story of savings under NYHA holds true for health insurance costs for DC 37 members. So me, I'm one of those. The cost of insuring a DC 37 member making $56,000 a year, which you can see on the left, would drop around $19,000 under the NYHA scenario. A major savings that could be applied to wages, pensions, or other benefits. Next slide, please. Okay, and we're going to get more into some of the counter arguments countering the disapproval that public sector unions have against NYHA and have used to fight against the bill. So under NYHA, employers will significantly save on healthcare costs. The cost scenarios we just walked through demonstrate this. Unions could negotiate as part of collective bargaining negotiations where these savings are directed to boost wages, salaries, retirement funds, or other benefits, which are all essential. Employers who currently claim in negotiations that they cannot increase pay or other benefits due to high insurance costs would no longer be able to claim this. They would lose this leverage in contract negotiations under a NYHA system. So it's a real win for workers. Unions, therefore, would gain leverage in collective bargaining. So this kind of counters the argument that unions might lose leverage under NYHA or lose control of healthcare. Unions could turn focus from negotiating health benefits to other crucial fights, such as securing higher pay, safer workplaces, very relevant always, but especially right now in the pandemic, paid time off, and more secure retirement plans. Next slide, please. Excuse me, just caused myself a joke. So, as discussed earlier on tonight, some of the main opposition to NYHA, and one of the reasons it didn't get a vote in the state ledge last year, is because of public sector union opposition. My own union, the leadership, put out a memo against it. So here are some of their concerns. New York public sector unions, like those represented by the Municipal Labor Committee, which DC 37 is included in, have fought hard to secure healthcare benefits from employers. This is, of course, commendable that they fought for our healthcare. The Municipal Labor Committee has voiced concerns that NYHA might decrease their ability to negotiate healthcare coverage and city contributions to union welfare funds, which currently fund eye care, dental care, and prescription drugs. The NYHA tax appears, as Stu was just discussing, on the face of it as an increased out-of-pocket cost on employees, with savings accruing to employers. Next slide, please. But there are certainly solutions to these public sector union concerns. Supporters of the New York Health Act, like us here, can advocate for these solutions in our activism. For example, existing union welfare funds could be perhaps used or repurposed for other non-healthcare purposes, like higher wages, paid time off, and more. Unions would still be able to advocate for their employees, especially in medical necessity reviews and appeals under the new NYHA system. And they could run their healthcare centers with New York Health funding. Next slide, please. Okay, so in 2018, two of the main legislative advocates for NYHA, which is Assembly Member Gottfried and Senator Rivera, they happen to be the chairs of the health committees in each house of our state legislature. These two members published a memo that they sent to the Municipal Labor Committee advocating for the addition of certain language to NYHA to address labor's concerns about the bill. So I've copied some of this language here. We think this language makes sense and would make NYHA stronger, an even stronger bill, and it would support the labor movement and address concerns. So to paraphrase the language, a public sector employee who pays no part of their health insurance premium would not be required to pay the new New York Health payroll tax. The employer would remain responsible for 100% of the premium. So for example, I currently, for my health insurance, do not pay premiums. I just pay copays. The city of New York pays 100% of the premium. Under this language in the first paragraph here, that would stay the same under the NYHA system. I wouldn't be paying a new 20% tax on my salary. So this provision would help labor protect its major wins for employees like those in New York City, for employees like myself who don't pay any premium for health insurance. And it would make sure that union members would not have their tax burdens increase. This saves working class folks like myself and my household some money. Language could also be added to NYHA to specify that any savings by a public sector employer will be allocated to wages or benefits, with the allocation subject to collective bargaining for organized employees. So I think this language is quite specific and strong in the sense that it would address some of those collective bargaining concerns that public sector unions have, and also the concern that savings would accrue to employers. This specifically states that any savings by a public sector employer would have to allocate savings to benefit employees. Next slide, please. Okay, this slide and the next one really excite me because I think it's something, the messaging around NYHA could really benefit the labor movement. If unions come out in force to support NYHA, there is a major opportunity for them to claim and message a union victory. This is something we can push in our advocacy, and this messaging could go a little something like this. Unions have helped New Yorkers and Americans secure fundamental civil rights and benefits, including healthcare. Passing New York Health Act would accrue significant savings for working people and families, while providing them with life-sustaining and, quite frankly, life-saving comprehensive care. Next slide, please. And if unions use their significant people-powered political capital to help pass NYHA, the passage of the bill would be a historic victory for labor. Unions can message to current and prospective members that they help secure the most comprehensive healthcare system in the United States. And the victory could be used as a major recruiting tool and a launch pad for other union campaigns for better working conditions, pay, and benefits. And I didn't write it out here, but it's been mentioned in the presentation already. It could really bolster the national conversation and campaign for Medicare for all. So that is my spiel, and I'll pass it off to the next person.
Thanks, and I'll wrap it up. I'll go through how union members have been involved so far, and then the various ways we have for union members to plug into the work. So last session, during the last legislative session, we started a project to help union members within DSA start single-payer healthcare caucuses within their locals. So we worked with around 30 union members representing about 15 different New York union locals, convening meetings every 2 weeks, and serving as a hub essentially for those union members interested in working to build support for single-payer healthcare within their unions. Towards this end, the group agreed to make a series of escalating asks of other members of their local, beginning with writing a 2 to 3 sentence statement of support and leading towards bigger asks that entailed forming a formal caucus within the local and generating an official statement of support from the local. What we came to learn last session is that a lot of how this works is that these memos of support or opposition get kind of stacked up by the legislators, and they compare how many they have of each, which is a kind of arbitrary system of doing it, but it's sort of how they operate. So what we tried to do is get as many memos of support from unions on the floor as possible to show that despite what the common narrative is, union members actually do support single-payer healthcare. At every stage of the process, members involved in this project were challenged to use these escalating asks to gauge where fellow union members were at in their understanding of and support for single-payer, helping them to identify existing supporters and help grow more. Part of the challenge that we're facing is that there are a lot of myths about the New York Health Act out there, and part of what these union members faced were dispelling those myths within their unions. In the end, we made contact with or helped to found 15 single-payer healthcare working groups or informal groupings within local unions, and 10 of those took action with us in the form of either a 3-sentence statement, a memo of support, or a resolution in support of the New York Health Act, which has laid serious groundwork for a longer multi-year effort to win labor support for the New York Health Act and show legislatures that union members demand single-payer healthcare. This year, our escalating asks are beginning with asking the union members who showed up to this to assess whether there's an appetite in your local for more information about single-payer healthcare, and if so, asking you to help us organize a presentation for your fellow members. This presentation that we just did was very generalized, but we want to work with union members to help you present this to your local and assess specific concerns that your members have and be able to answer them in a presentation like this. So how can we pass the next section? As everyone was saying, union leadership does not support the New York Health Act right now. And they'll only do it if they feel pressure from their members that they have to do it. So like I said earlier, the biggest first step we can take is organize healthcare caucuses within locals to push for the New York Health Act and present New York Health Act 101 to members of your local, answering specific questions, like I said earlier. Finally, the ultimate goal of agitating for those memos of support to be sent out to let politicians know that union members demand universal health care. How do we organize within our locals? Like what we're doing now, it's about talking to your coworkers about the New York Health Act, sitting down and understanding, what are the specific concerns of our members? Why do union leadership feel that members don't support it? What are those concerns and how can we address them? And find allies within your locals that want to do that with you. Gathering those questions and concerns of your coworkers, and then working with us, DSA, to organize answers for them. Our goal is that we could work with any interested locals in adapting this presentation specific to your locals. So answering questions that any of your members may have, making that cost comparison slide we did very specific to your locals and the healthcare costs you face, and helping you present that to your locals. And then finally, push your local to draft a memo of support, letting the politicians and union leadership know that New York union members want and demand single payer healthcare. Couple ways to get involved. Zach is going to drop in the chat right now a form that you can fill out if you're interested in any of the in pursuing anything that I just mentioned with us, and we can get in touch with you after and focus on next steps. So if you're interested in trying to present to your local, or you want help adapting these slides to your local, or you're interested in forming a healthcare caucus, or you already have a healthcare caucus, anything like that, fill it out. And yes, as most in the chat, we'll connect you with either the New York City chapter working on this or any of the upstate chapters working on this, and help you adapt this to your local. Finally, I'm going to kick it for one last slide to Ursula from the Campaign for New York Health, who's one of our coalition partners for the New York Health Act, who has a couple of specific tools that they've put together.
Thanks so much, Noah, and really just big snaps to all of you who prepared this presentation. I think it's really a great offering for everyone that wants to build labor movement support for the New York Health Act. So on the screen, we've compiled a few actions where we think it would be really valuable for union members to take action. Although the first thing I would want to say is that I'm not sure if it's been mentioned tonight, that it's not that the labor movement and labor leadership opposes the New York Health Act. I think it's helpful to think of the labor movement as split on the New York Health Act. We have to recognize that the largest nurses unions, the largest healthcare worker unions, hospital staff unions support the New York Health Act, and the opposition has really done a great job of creating this narrative that makes it seem as if all of labor opposes the Health Act. So our work going forward is really to bust that narrative and really stop unions from doing the insurance companies' dirty work for them. The first tool that's on the screen, it's something new that we're trying. It's a tool that will allow you to send a message automatically to Senate Leader Andrea Stewart-Cousins and Assembly Speaker Carl Heastie, where you can identify yourself as a union member. You can insert elements of your personal healthcare story if you would like. And with a click, you send it to them. And we've designed it very specifically so individuals can have the option of identifying their occupation and their constituency. And we really want to drive home that we want Stewart-Cousins and Heastie to hear that members of labor do support the Health Act. Another thing that's coming up around the state that you all may already be part of is that the Campaign for New York Health and coalition partners, hopefully members of DSA chapters, are going to be organizing lots and lots of lobby meetings in support of the New York Health Act. And we want to make sure that every time we meet with a legislator, there is at least one member of labor there that is making the case for why the New York Health Act is good for workers, good for the labor movement. So if you want to join a lobby visit in the coming months, you can fill out the lobby visit link. And then finally, at the end of the last legislative session, Senator Jabari Brisport launched an Educators for the New York Health Act sign-on letter. We think that this is a very important tool to build support within NYCIT, within UFT downstate and across the state. For many years, New York State United teachers supported the New York Health Act, published memos of support, donated money to the Campaign for New York Health, showed up for public hearings to support the Health Act. And in 2018, when Democrats got a majority in the state legislature, NYCIT withdrew their support and now is actively in opposition. We've identified NYCIT and UFT as public sector unions that are most movable and that we can neutralize. And DSA especially, I think, is an organization that educators are drawn to, lots of socialists who are teachers. So we hope that you all will help circulate that specific Educators for New York Health tool to really build support, a rank and file support within the educators unions. And I guess I'll stop there and just say I'm really looking forward to working together to increase the pressure for passing the New York Health Act this year.
Thanks, Ursula. And now we have some time left. So if anybody has any questions about anything we went over, feel free to drop them in the chat now. And hopefully we can answer them. In the meantime, all of the various links are in the chat now. I'll drop in again the form to get involved with the work we're doing if you want to have us present or have help forming a healthcare caucus. And the various Campaign for New York Health links are also right there. So please fill out all of them, but I will also send them out after for anybody who missed them. Yeah, and if no questions, then that's all we had. Thanks everyone for coming. Robert, go ahead.
Getting a few. Mm-hmm.
Well, sorry it took so long. I see people leaving. And thank you for the presentation. I'm in the same local as Nick, local 371 of DC 37. And our union president got featured last year in the top 100 list of union leaders for specifically his opposition to the New York Health Act for all the reasons outlined. But to me, there needs to be kind of a separation between the union leaders and the membership, right? Unfortunately, the leaders are bureaucratically deciding the response to the New York Health Act. But I still think there is a challenge to like the everyday rank and file worker as to why they should support the New York Health Act, not just rhetorically by saying, yes, I support it, but like by then lobbying within their unions and going up against their union presidents to say this is a change that needs to be made. But I think on an even bigger scale, I think the presentation put forward very clearly why it's logical, reasonable, cost effective, and all these other things to put forward the New York Health Act. What I'm not hearing is how we hope to win it against the intransigence of politicians and the rich people they mostly serve. Like everywhere else, there's a form of universal healthcare. It's usually come on the back of like workplace actions, protests, some type of mass movement of people getting activated after being outraged. And we're in the midst of a COVID-19 pandemic, which is showing really and truly the limits of our healthcare system. And, you know, we're coming off a year ago of this big rebellion for Black Lives Matter. So clearly people are rehearsed in how to protest and shut shit down. And to me, my question is, how do we then address that missing element? Like, how do we fight for the New York Health Act? How do we have some kind of a militant response? How do we get people activated? Because clearly the game of negotiation with the union leaders has not worked, with the politicians who are the key people leaving it behind. Like what is the action plan, I would ask? Because like, if I was to try to convince the person sitting next to me at work to support the New York Health Act, I think they have a healthy dose of cynicism about politicians' likeliness to change based on hearing good facts and so on. So like, what would we tell them how we win this demand?
Anyone else who has a comment on this, feel free to jump in. But I think the way I view it is that these politicians and union leadership aren't going to bend unless they feel that they have pressure from either their constituents or their members that they have to do this or their jobs will be threatened, right? And like you said, there is a lot of anger out there, but we are the anger is very unorganized, especially amongst politicians' constituencies and labor. There isn't a centralized way for people to get involved, and because of that, union leaders and politicians especially don't feel any pressure. They don't feel like there's a big push to make them do this. So what we want to do is on two fronts, make both of those groups feel like they can't use that excuse anymore. So for politicians, once the legislative session is going to start, we're going to have constant phone banks and canvasses and rallies and other actions to make sure that politicians know that they can't keep getting away with not passing this, that their jobs will be threatened if they don't pass it. And the same with union leadership. We want to build support amongst union members and make them or help them let their leaders know that there is support amongst their members for this. And that just like politicians, their jobs will be threatened if they keep putting up barriers to this. If anyone else has any other comments on that, feel free to jump in, but I'm going to jump to the next question just in the interest of time. It was asked about the financing of the bill not being in the legislation. That's true. Technically, the bill, Jeff just answered in the chat, probably better than I could, so I'll just read his answer. The bill does not technically specify tax brackets at this time, but it does specify a $25,000 exemption for everyone and a $50,000 exemption for seniors. And it also specifies that the tax will be on income from employment and investments. The way this kind of has to pass is it needs to pass through the legislature first, and then in the budget process the next session. But we have ideas of what the tax brackets that'll look like that are floating around, like one that was in the presentation today, which is also one of the most conservative estimates of what those taxes will look like, because it was from the RAND Corporation, which is a centrist-leaning think tank. So we kind of know what the downside will look like, and in reality, the taxes will only look better than that. But technically, yes, we wouldn't know what those look like until after it passes. And then Jean asks, why haven't those changes detailed in the memo Godfrey and Rivera sent to the municipal unions been added to the bill? I actually don't know the answer to that, but I see Yuling was answering a bit in the chat. Yuling, could you elaborate on that?
I'm sorry that I haven't looked at the MLC memo in a long time, but we have made Godfrey and Rivera have made amendments to the bill in the past like 4 years because of conversations with unions. So I don't know if those specific ones are all like in the bill, but we've made other changes. I don't know, that's not exactly an answer, but that's the information.
Yeah, and I'll just add, as I understand it, these are specific provisions are still, they're not dead by any means. They're still being negotiated to be added in. So there's, if there's pressure that these need to be added in, then they'll likely be added in.
I just wanted to comment on that too. Looking at some of the language that they propose to include, I feel like it makes sense that if some of the unions may be fighting back against the bill with those concerns about, well, people would end up paying 20% when they pay nothing now, or the benefits won't accrue to employees. We can point to, well, it's very possible to write it into the legislation that those requirements are stipulated. So we have solutions. So I think we could push for certain language to protect workers too. But if anyone wants to add on that or correct me at all, please do.
And then Maureen asks, has your task force contacted the New York State School Boards Association? We have not, or at least DSA hasn't. I don't know if other groups have. So I can't speak to specifically how their response, what their response would be, but Maureen, I'd be happy to follow up with you after, because that sounds like an interesting idea. And I think that's all the questions. So if any others, feel free to jump in. But if not, thank you everyone for coming out. And I will be in touch with all of you soon about building that pressure we were just talking about.
Good night, everyone. Thank you all.
Thanks, folks. Take care.